Good morning, everybody. My name is Claire Curtis, and I'm an Engagement Programmes Manager from the Community Engagement Directorate in Healthcare Improvement Scotland, and I'm going to chair this morning's session. I think we're going to still have a few people coming on for the next few moments, but I suggest we just get ourselves started. I'd just like to introduce the speakers that we have today who will come on shortly. So there's Stephen Lithgow, who's an Associate Improvement Advisor in the Focus and Dementia team in the iHub. Stephen, do you want to just switch on your camera and say hi?
Hello everybody, good morning, nice to see you all, great turnout, so I'll catch up with you later, thanks.
Thanks Stephen. And then Lynn, Irvin and Helen Skinner. Lovely joint photo of you both, Lynn and Helen. Do you want to just say hi?
Hi, this is Helen. Really looking forward to this morning and all the discussion that's going to take place.
Morning folks, I'm Lynn. Great to see so many people here, and I hope the session is what you're looking for.
I'm sure it will be, Lynn, thank you. I'm really curious, I know we have some people from all over the country, so just as I kind of get us started, can people hear okay? I'm just seeing there's some issue with volume. Hopefully we're getting it sorted. Wendy, hopefully you'll hear something now. You can let us know. I'm just wondering where everybody is this morning. So I wonder if you could just add into the chat box whereabouts in the country you're from. I know we have some Welsh friends on, so we were very curious to see whereabouts you were. Snowy Fife. Hello, Cardiff. Feels a bit like Eurovision. Wow. Hi, morning, Ruth. Just saw you there. Okay, so I think everybody has switched their cameras and microphones off, so we will just get on with the session. So really the purpose of today, apologies, all my chat's coming up even though I blocked it. I can't actually read my notes at the moment, so apologies. Just a little bit of housekeeping, just to remind you. Lynn, could you move on to the next slide, please? Have your microphone muted and your video turned off. And hopefully that will let the system work with the number of people that we have on. That's great, thank you. And again, just a reminder, as we said in Eventbrite, the session is being recorded, so just for your information, so we'll be able to share that at the end of the session. So why are we here today? Lynn, could you go to the next slide, please? As some of you will know, we've been working, the Community Engagement Directorate have been working over the summer on a bit of work to understand the access and equity of virtual visiting for inpatient hospitals across Scotland. We have worked with every health board now, and we'll tell you a little bit more detail as we progress through the session of where we're going and how that's working and how virtual visiting is actually working in practice. The next session is going to be Stephen, as he introduced himself a moment ago, and he's going to look at specifically the issues around dementia and virtual visiting. Then we're going to hear from the real world from Lynn and Helen about what it's like and how to keep people connected, patients connected as much as possible whilst in hospital. And then the final section is really going to be about practical ways forward and a question and answer panel that hopefully we will strive to answer as many of your questions as possible. I think given the numbers that we have on today, it's fairly safe to say we're not going to get through everything. So my colleagues in the background, there are lots of them working to theme and collate your questions, and what we'll do at the end of the session is we will produce those all on the website. So just to reassure you, we're going to try and get our way through everything. We just appreciate we might not get it with all the numbers today, and we don't think we'll have enough time to allow people to kind of ask lots of questions, so apologies again, but please remember the session's been recorded, so you'll be able to share it with your colleagues, listen back, and hopefully we'll be able to answer as many of your questions as possible. Next slide, please, Lynn. So it feels strange introducing myself again. But my name's Claire Curtis. I'm, as I said, an Engagement Programmes Manager in the Community Engagement Directorate, and I work in the west of Scotland predominantly, although the work that we're doing is across the whole of NHS Scotland, and the work we've been involved in is for every inpatient area in Scotland, so big scale. So I'm going to cover the background into the virtual visiting scoping exercise, where we've got so far and some of the findings, and then kind of pull that down specifically into some of the learning we have around dementia and kind of where this session came about, because I think we've been really intrigued to find out, and this was an area we identified was probably needed a little bit more of a focus. I think that gave us a really lovely opportunity to work with our colleagues in the iHub to think through what were the specific issues around virtual visiting for people with dementia in hospitals, and what could we do to try and help with some of that. So that's the aim of today, and we're hoping that there will be some outcome papers, output papers from this. So we'll have the recording of the session. We're going to share quite a lot with you in the chat box of different resources, and hopefully we're working towards developing kind of good practice guidelines for people working with patients with dementia in hospitals. I'm very mindful that there are quite a lot of care home staff who the same issues and theory, the same thoughts may apply to. So please, the focus is on hospitals because of the scoping survey, but we're very aware people with dementia in settings that aren't necessarily their own home may be something that you're wanting to consider as well. So please contribute to that, and we're really hopeful that what we get today is a kind of good reflection of what it's like in the real world. I'll also talk a little bit about the next steps for our work. Len, could you go to the next slide, please? I think there's an animation in this. Sorry, Lynn, you'll need to do another one as well. So I think the bit to really start, sorry, Lynn, could you just click one button on? I think the section comes up for the programme for government. Thank you very much. The joy of animations on slides. The programme for government in 2018 to 2019 contained a commitment to develop person-centred visiting, and the definition of person-centred visiting was about increasing flexibility and removing set visiting times. And I think that's really back to the component I should have said. Some of you will know me from I previously was the Associate Improvement Advisor in the Person-Centred Health and Care team within the iHub, so I know a few of you from those days as well. But person-centred and how that works, and that was about making it work for the individual who was in there, and I think that's really relevant to the session we're going to do and talk through today. How do you make virtual visiting person-centred? But where this work came from was the commitment that there was to make sure that people were able to access their loved ones as much as possible whilst they were in hospital. Next slide, please. But there was a fairly big flaw in that plan that none of us could have predicted. I don't know how many coronavirus slides you've been to or seen in the last few months, but I certainly know for myself. The reality is by April 2020, every board was really on board and looking at how they were removing their set times for visiting and how they could work on that. And then the month before, literally everything happened. I'm very aware Ruth Jace is on the call, and we probably have lots to add to this as well about the reality of what happened to person-centred visiting, and the reality of, unfortunately, what had to happen for people is that nearly all visiting was halted immediately, and unless it was apart from exceptional circumstances and end-of-life care, unfortunately, it wasn't safe to let visitors in. And I for not for a second would even comment on how harrowing and hard that must have been for everybody involved. I think we've been really privileged within the Community Engagement Directorate in the last couple of months to really hear the emotional impact that's had on staff, never mind what that did for patients and families. And I don't think we can underestimate the impact that that's had on it, and also how people must feel. So I think it's really important to remember this really strikes at the core of practitioners and what it feels like to separate people and knowingly separate for the best of reasons and out with everybody's control. But I think I would never like to dismiss or make that sound like it wasn't a really big, difficult exercise for everybody involved. Could you go to the next slide, please, Lynn? So what is person-centred virtual visiting? I think the most important factor to say is this is not and never can be a replacement for person-centred visiting. The concept of virtual visiting is whilst, for whatever reason, people are not able to physically see each other, what can we do to connect patients with their loved ones while they're separated and in hospital or potentially again maybe care homes? I think that's really, really important. It was almost implemented and then it had to change, and that was really, really hard for a lot of people, as I've said. I think what is really important and what we're hoping about person-centred visiting, virtual visiting, is that it's a legacy of COVID, and I mean hopefully a positive legacy, because what we have found, we've heard some really amazing stories about, my colleague shared the other day about people in Australia being able to see their loved one in hospital that they would never have the opportunity to. Equally, we've been working with quite a lot of the national boards. So Golden Jubilee have said how, because it's a national board and people have to travel a long distance, very often they don't have visitors, and the potential capacity of virtual visiting to help support that when people can't connect in the way we would like to would be positive. But I think it's really important to say this is only ever meant to be as an add-on and an addition to person-centred visiting and that flexibility. So where did boards get to? We were asked, if you could move to the next slide, please, Lynn. Thank you. So the Community Engagement Directorate, and I again should have, apologies, not said this yet. The Community Engagement Directorate was previously the Scottish Health Council, and we changed names on the 1st of April this year, so right in the middle of this we changed. So just again to clarify where this comes from, but the Scottish Government asked us to undertake a scoping exercise and really understand what access to virtual visiting is there across the inpatient beds in Scotland, and is it fair and equitable? And I think, again, there are people on the call today who can really testament much more to this than me. The rush to implement virtual visiting when lockdown happened in March was just phenomenal. And everybody did everything they possibly could, from donating iPads and old phones, and staff using their own phones for people. Some boards managed to access money and bought iPads and had systems set up, but everybody just rushed to do whatever they could, understandably because of the nature of it and because it was closed so fast. So I would never like it to sound like I'm not completely in awe of what people managed, but we are aware that we could really look at how we could help make that much more sustainable. And as I say, a legacy, a positive legacy of COVID, that there is equipment in place and a systematic response to how we support person-centred virtual visiting across Scotland. Nearly everyone had some form, which is really interesting, and I'll talk a little bit about our early findings in a moment, but nearly every board had some form of it. But again, I think it's safe to say there was not a systematic process, and every board had to come up with a pragmatic solution, which may have been different between one ward and the next. And again, I think that's the scale of what had to happen was really quite daunting, to say the least. Could you go to the next slide, please, Lynn? So we had 14 territorial boards and 3 national boards have responded so far, and we're just at the process of developing an SBAR report and business case to Scottish Government. So I'll talk a little bit more about that in a moment. The 3 national boards were the Golden Jubilee Hospital and the State Hospital, and we also in principle included the Louisa Jordan, purely because we were looking at, if that became an inpatient service, what would we do and how would we work with that? And I think that was really interesting, but it was more a paper exercise about how would you do it if you had the time and the practicality. So we've still got that on hold, and Louisa Jordan are kind of involved in principle in case the circumstances change for there. Hopefully not now. Most have implemented some form of virtual visiting, but very few had it completely systematically across every area. There was quite a lot of evidence of, because people had rushed to do it, they had just found pragmatic ways of doing it, and the potential that we learned from some of the boards who had managed to apply it systematically. There were 5 boards who completely applied it systematically, but what we found is the more of a system and a process you could make, the better. And the real joy came, I should have said, the person-centred visiting leads that I mentioned earlier. they were identified, predominantly it was the person-centred visiting leads, became the operational leads for us for the scoping work that we were doing. So it was the same people who'd been trying to implement person-centred visiting, who were then often took the responsibility of the virtual visiting rollout. And where it works absolutely best is when the person-centred visiting lead and the e-health lead for the board communicated and worked out the practicalities. And I certainly have learnt quite a lot, it's safe to say, about the technology, pragmatic processes there are, and whether you use patient Wi-Fi, whether you use corporate Wi-Fi, what additional apps and supports you can put on devices for people. It's really quite fascinating about the potential for, this system. I think what we did really find is that there was further staff support needed, because again, people had just rushed and it was quite often person dependent on areas, rather than there being a systematic process. And also the information and the communication to families was really important, because how do families know about the virtual visiting process? How do they find out? So there are a lot of lessons for us, and we've kind of changed the focus of the work now. So we're calling this phase 1. So phase 1 is about understanding the system, understanding what resources are needed, and we move into phase 2 in January, which is about, we're in the process of purchasing devices for the areas where there wasn't a Wi-Fi, sorry, not Wi-Fi, well, sometimes Wi-Fi, but where there weren't devices and resources, and so that we can help that. But the implementation phase in phase 2 will look much more at supporting an equitable service. I probably want to move on to gaps now, and I think care of the elderly and dementia came up as a really specific area of where this was much harder. And again, where we thought, actually, there's probably some work we could do with our iHub colleagues for the Focus and Dementia team, and it felt a really good opportunity for us to kind of look at that from an improvement perspective. Interestingly, there were some other gap areas that I'll not talk a lot about today, but maternity was another area where there were quite a lot of assumptions made about women's access to equipment, and similarly mental health. So we're doing some other work in other areas on this work as well. Lynn, could you go to the next slide, please? So what did we find so far specifically about people with dementia in hospitals? Availability really ranged and varied. The support and the practicality, and again, I'm under no illusions about how difficult it could be. I'm just looking at that lady's birthday cake. I hadn't noticed it in the picture before. How lovely. How difficult that is when staff are already really pressured, and hopefully today we're going to have that kind of honest conversation about some of the really pragmatic difficulties there are. But we're really aware there were some areas of amazing, excellent practice, and you're going to hear more about that today, about the way that we've mitigated, and our colleagues and our practitioners have found ways to magic this and make it work somehow. I think what we're really aware of is that complete lack of connection, and Stephen will talk a bit more about this, about the risk there is for that for everybody involved. And I think it's really important that we look at that a little bit more. Next slide, please, Lynn. I think my colleague Anne McClinton is on today from NHS Greater Glasgow and Clyde, and just a little bit of a shout out to GGC, because they really, really supported. They were one of the boards who systematically went through a process, and I'll just let you read this for a moment. I would really recommend, there are some fabulous resources on the NHS GGC website to really understand the impact it's having, and there's just the most glorious film about staff talking about what difference it made to them while they were trying to work around COVID, and how difficult practice was, but actually where virtual visiting really, really helped. And I would really strongly encourage you to have a look on that website. I'm sure there's lots of others, but I think it's really nice. Next slide, please, Lynn. Thank you. So the next steps for virtual visiting from the Community Engagement Directorate's perspective. We're really, really keen to try and capture the real factors, what really matters about delivering virtual visiting to people with dementia in hospitals, and developing kind of top tips. So we're really wanting to look at a best practice guide, and that's what we're hoping, as I say, will be part of the feedback from today that we'll be able to do. The phase 1, we're just in process of finalising the report and gathering a business case for the additional resources that are required to try and improve the equity across the system. And then phase 2, as I say, from January, we'll look at the implementation and really get boards to consider particularly where the gaps are and how we can support them to develop a systematic process. I'm saying that quite lightheartedly, and I'm very aware there are a lot of people on the call who are involved in this work, because a lot of my engagement officer colleagues are on. That has to be different for every board and every area, and it may be different by hospital, again, even by ward specific. So there are lots of pragmatic things that people are having to work through, but hopefully that's something that we're really going to work on over the next few months to make sure that we have an equitable, sustainable service across Scotland that will be board specific. I think I'm hopefully labouring that point, but hopefully not labouring it. It's really important because it really depends on the systems and the infrastructures for each area. And the phase 3 will be really looking at the evaluation and particularly what matters to the people having the calls, so the people with dementia, their families on the other side, and how we can do that. And hopefully we'll hear a little bit more about that today. Thank you very much. That's me done for now. I'm going to pass over to Stephen Lithgow, and I probably should have said apologies for, we'll have an opportunity in the Q&A panel for questions, so if there's anything you wish to ask, please write it in the chat box and we'll make sure that that's pulled back through later on. Thanks, Stephen. I'll pass over to you.
That's great. Thanks, Claire. Can I have the next slide, please? Thank you. That's great. So good morning. It's Stephen here from the Focus on Dementia team, and I'm an associate improvement advisor, presently working on a dementia in hospitals collaborative with 8 hospital wards. And we're looking at person-centred planning. And so I'm also working alongside Lynn and Helen, who will be presenting shortly. And previously I worked as an occupational therapist in Greater Glasgow and Clyde. So Focus on Dementia are really thrilled to co-host this session, and it's really great to see such a big turnout today. So in this section, I kind of want to sketch out what's been happening around dementia in hospitals in Scotland, just to sort of set the context around a range of sort of lots of positive developments which have happened, and then kind of focus a bit more on the person with dementia, that kind of individual who's engaged in virtual visiting. So as to think about the person a bit more rather than the sort of technology per se, because I think that will be kind of looked at a bit later, and then I'll have a quick look at some of the emerging literature. But first of all, we're going to have a quick look at your Slido feedback, which has been really helpful. So could we have the next slide, please? Okay, I think we should have the results in that slide of the, okay, I think we've got a previous version, but not to worry, I can just quickly talk you through them, and we'll send that slide on to you. So we asked you basically what are the main barriers to implementing virtual visiting in your area. And we were looking for you guys to vote on the first 3 of these, and the results that we had, the top 3 are as follows. So apologies if I sound a bit like Les Dennis here. So in third place, we had staff knowledge and skills around technology. So that was the third place barrier, which was 56%. In second place, we had the ability of staff to support virtual visiting. So I think, you know, in terms of their time, and you know, we think about the disruption that COVID has brought to us. And then in the first place, the greatest perceived barrier is actually engaging the person with dementia, and that came out at 72%. So we'll get that slide pulled to you, but that's just a snapshot, just to sort of have a sense of what are the top barriers. Now, we had also asked you guys if you could let us know what the other barriers might be, and we didn't record these individually. So I was just wondering, as I progress through the presentation, if you could maybe put into the text box some of those other barriers that you think are in the way of us providing virtual visiting for people with dementia. Okay, so please feel free just to put in some of those ideas, any of those other issues that you think are you know, pertinent, other barriers. So could we have the next slide, please? Okay. So we think around 25% of hospital beds are occupied by people with dementia, and then the length of stay is approximately 6.9 days longer than those without. So that is a very large group of people, but each of those is an individual, of course. with a differing personal experience of dementia in different parts of the hospital system. So some of that might be an acute hospital or a community hospital or in a specialist dementia unit. And there are obviously differences between hospitals and within. There may be differences in staff knowledge and skills around dementia, the dementia friendliness of the environment, care planning and activity provision for people with dementia. But the constant issue is that we need to try to support virtual visiting as best we can. And I'm saying as best we can because it often depends on that person's ability to engage in virtual visiting at a time, at that specific time, due to things like levels of stress and distress, which can obviously change. But people with dementia shouldn't miss out on the opportunity for virtual visiting just because they have dementia per se. So hospital care for people with dementia has been a focus of dementia policy since the first dementia strategy in 2010, and we're now actually on our third strategy. And the existing strategy, I think, fits well with with virtual visiting. Commitment 7 looks at improving the care for people with dementia in acute and specialist care. Virtual visiting helps that. I think, interestingly, Commitment 11 looks at technology and dementia. So the dementia policy states that we will continue to explore innovative ways in which technology can be used and adapted for people living with dementia. And I think virtual visiting does that as well. I think another aspect of the dementia strategy is dementia inequalities. And I think we want to make sure, I think as Claire had mentioned, that people with dementia there seems to be a bit less provision around virtual visiting for people with dementia. So we want people with dementia to have equal access, if you like, to virtual visiting. So why is dementia policy important? Well, there's probably two key things. The first is that it set up a really great infrastructure, I think, to support better dementia care, which we'll talk about in a moment. And I think the second thing is that there is a growing cultural change towards person-centred care in dementia. And this is something that's been happening for quite a while, and a rights-based approach to dementia. So if we think about that kind of infrastructure,